Hi, my name is Osama. Naga will discuss in this section metabolic disorders. Check the third edition for all updated information. My objectives in this presentation: understanding laboratory tests that aid in the diagnosis of metabolic diseases, recognize the metabolic disorders that is considered medical emergency and require prompt diagnosis and treatment, early recognition and diagnosis of metabolic disorders. Close to possible metabolic disorders: the newborn is normal at birth, then becomes sick. May present hours to years after birth. So metabolic disorders may present hours to years after birth, depending on the type of underlying metabolic disorder and severity as well. When you have a case of suspected metabolic disorders, this can be with sugar, protein, or fat. In cases of sugar, you may have a problem with glucose metabolism, like cases of hyperinsulinemia; galactose, like cases of galactosemia; fructose, like cases of fructosuria. In cases of protein, there is a three major classifications according to the presentation: urea cycle disorders, like in cases of OTC or ornithine transcarbamylase deficiency; citrullinemia; argininosuccinic aciduria. Cases of amino acidopathy, like maple syrup urine disease, phenylketonuria, and homocystinuria. Cases of organic acidemia, like propionic acidemia, methylmalonic acidemia, and glutaric acidemia. Or you have a problem with fat, like fatty acid oxidation disorders. If we have a newborn presents with poor feeding, lethargy, vomiting, seizures, or coma, and the seizures are not responding to IV glucose or calcium, the most common cause of this presentation is sepsis. Second most common cause is sepsis. Third most common cause is sepsis. Metabolic disorders are rare but very important to consider. In this case, check the ammonia level. If the ammonia level is normal and normal anion gap, most likely you are dealing with amino acidopathies or galactosemia. If the ammonia level is high or very high and the normal anion gap and respiratory alkalosis, most likely you are dealing with urea cycle disorders. So urea cycle disorders, a high or very high ammonia level with normal anion gap. If the ammonia level is normal or high, but you have metabolic acidosis or high anion gap, this is a case of possible organic acidemia. So this major classification will help you to identify which group of metabolic disorders you are dealing with, because the ultimate management is different. But in all these cases, if you give dextrose or glucose, you will never have any problem. But it's very important to know how to differentiate between these disorders. We'll start with protein disorders. I will begin the protein disorders with this case presentation. This is a 15-month-old girl, previously healthy, presents with acute onset of weakness, lethargy, decreased responsiveness, and dilated pupils. Vital signs: respiratory rate 45, pulse 145, blood pressure is normal. The sodium is 140, potassium is 4, the chloride is 98, bicarb is 5, BUN is 22, glucose 45, and ammonia level is 57. The ABG, the pH is 7.02, is very acidotic. The CO2 is 19, the oxygen is 123, and the bicarb is 4.8. What is the most likely cause of this presentation? The keyword in this case: this is a 15 months old, previously healthy, and it presents with acute onset of mental status change. Of course, ingestion of toxic substance is very important to consider in this case. But if there is nothing to explain, this is most likely metabolic. If you look at here at the electrolyte and you do you calculate the anion gap, you do the sodium plus potassium minus the chloride plus the bicarb. So you have here 144, which is the 140 plus 4 here, 144, and the 98 plus 5 is 103. So the anion gap here is 41. So this is very high anion gap. So you have metabolic acidosis with normal ammonia level. So this is a case of organic acidemia. So the key word for organic acidemia is high anion gap, metabolic acidosis normal or high ammonia level. Organic acidemia is a high yield. Very important to be familiar with these two names: propionic acidemia, methylmalonic acidemia. Both they present with metabolic acidosis, high urine ketones, a high anion gap, mild to moderate hyperammonemia. The point of differentiation between organic acidemia and urea cycle defects is metabolic acidosis. Both they may have very high ammonia level, so the point of differentiation is metabolic acidosis. In cases of urea cycle defects, they do not present with metabolic acidosis. So what to do at this point when you have a newborn or a child present with suspected metabolic disorders? You need to review the newborn screen if it's available, and send the urine for urine organic acid, the blood for plasma amino acids and plasma acylcarnitines. Immediately start with dextrose 10% with salt. Correct metabolic acidosis, no protein to be given, intravenous lipid emulsion. In severe cases they may require dialysis. In this case you may save the life of this newborn. Initially, it's very difficult to differentiate between propionic acidemia and methylmalonic acidemia because both they present the same metabolic acidosis, mild to moderate or even severe elevation of ammonia level. But when you have the results back, you will be able to differentiate. In cases of propionic acidemia, it's easy to remember propionyl CoA carboxylase deficiency, and in cases of methylmalonic acidemia, methylmalonyl CoA mutase deficiency. When you have the results of the urine organic acid, you will see elevation of propionic acid in cases of propionic acidemia and methylmalonic acid in cases of methylmalonic acidemia. Both in newborn screen they will have elevated C3 acylcarnitine. Be familiar with this number, elevated C3 acylcarnitine. In plasma amino acids, it may show elevation of glycine in cases of propionic acidemia, glycine and alanine in methylmalonic acidemia. Glutaric acidemia type 1 is a very important cause of organic acidemia. Is because of deficiency of gluteryl CoA dehydrogenase enzyme. Is well known as cerebral organic acidemia. These patients, they do not present with metabolic acidosis like cases of propionic acidemia and methylmalonic acidemia. So it is difficult to diagnose because commonly they have normal metabolites, no metabolic acidosis. But when they do have acute febrile illness, they will present with catabolic crisis. These catabolic crises will cause injury to the basal ganglia, and they will present with dystonia and movement disorders. They do have macrocephaly, and they may present also with subdural hematoma, and this can be mistaken with child abuse. Very important to remember the keyword for glutaric acidemia type 1, macrocephaly, and subdural hematoma, which can be mistaken with child abuse. The way to know or to diagnose this condition by sending urine organic acid, and you will see high urine glutaric acids in urine. The second classification of the protein disorder is amino acidopathies, maple syrup urine disease, phenylketonuria, and homocystinuria. Maple syrup urine disease commonly presents during the neonatal period with poor arousal and poor feeding. If it's not diagnosed or is not managed quickly, this infant can go for coma and death. Is because of deficiency of branched chain alpha keto acid dehydrogenase enzyme. The key word for this disease is elevated leucine, isoleucine, valine, and allo-isoleucine. Elevated allo-isoleucine is diagnostic. They may have metabolic acidosis and ketosis. The reason for the maple syrup smell is the leucine. But if the leucine is not elevated, you will not have the maple syrup urine smell, and this does not rule out this disease. So do not use maple syrup for screening. If it's available, it's helpful in the diagnosis, but if it's not there, this does not rule out this disease. Very important. Classic presentation of maple syrup urine disease is urine smells like maple syrup because of elevated leucine level. Usually presents between 3 to 5 days of life with feeding difficulty, irregular respiration, loss of motor reflex, severe seizures, and death from cerebral edema if is not treated. Treatment is dietary control of leucine, isoleucine, and valine. Phenylketonuria is a high yield. Very important to remember all the details about this disease because simply is a preventable disease. If it's managed appropriately, you will save the brain of this child. The PKU is the most common inborn error of amino acid metabolism. It's because of deficiency of phenylalanine hydroxylase enzyme. This enzyme is important to convert the phenylalanine to tyrosine. And if you do not have this enzyme, you will have elevation of phenylalanine and deficiency of tyrosine. And this elevated phenylalanine will accumulate in the brain silently and will cause permanent brain damage and cognitive dysfunction. Very important, very high yield. Clinical presentation of phenylketonuria is fair skin and fair hair. So the skin will be light color and the hair will be light color if you compare that to the rest of the family members. Eczema including atopic dermatitis, light sensitivity, and hair loss. If left untreated, this will cause disastrous intellectual disability, and this can go down even to 30 or even less. Musty or mousy odor, epilepsy, eye abnormalities, which is hypopigmentation. Very important to be able to diagnose it because you can prevent this disastrous outcome, which is low IQ or intellectual disability. Diagnosis: elevated phenylalanine and deficiency of tyrosine. Brain imaging may show areas of demyelination and volume loss in severe cases. Treatment of phenylketonuria must be started before 14 days of life with phenylalanine restriction. These cases usually treated in a specialty metabolic disease clinic with providers or doctors and dietitians are familiar with treatment of these cases. Phenylketonuria, it is a challenging, is not an easy condition to treat. Also, they should be supplemented with medical food, essential amino acids, vitamins, and minerals. And recently, BH4 is recommended. So the treatment should be supplied or started before 14 days of life. Monitoring of phenylalanine level during neonatal period is recommended to be 1 to 2 times per week to keep the phenylalanine level between 2 to 6 milligram per deciliter. And once a month at least testing during childhood and adulthood. So the treatment is lifelong. You need, just to give you an idea, the food rich in phenylalanine and this food should be avoided, like chicken, beef, salmon, turkey, yogurt, cottage cheese, peanuts, bananas, avocados. So it is complicated to manage these cases. You need a dietitian, you need a specialty clinic familiar with these cases, and to provide medical foods and to give imitation food for this patient to be able to survive with no problem. If there is a female with phenylketonuria become pregnant without pre-conception counseling, without control of the phenylalanine level throughout the pregnancy and before, this can cause dysmorphic facial features, microcephaly, IUGR, congenital heart disease, intellectual disability, and learning disability. So planning before conception is critical. Homocystinuria is because of deficiency of cystathionine beta synthase enzyme. This will cause homocysteine elevation in blood and urine, and in newborn screen you will see methionine elevation and also in plasma amino acids. The clinical presentation of homocystinuria: intellectual disability, tall stature, osteoporosis, recurrent thrombosis. This is high yield, ectopic lentis or dislocated lens downward. Management is betaine supplementation. This will help to decrease the plasma homocysteine, aspirin to prevent stroke, dietary methionine restriction, B12 folic acid, and pyridoxine supplementation also will decrease the homocysteine concentration. Very important to know the differentiation between homocystinuria and Marfan syndrome because both of them, they are tall, both of them they have dislocated lenses. So in cases of homocystinuria, the inheritance here is autosomal recessive. Marfan is autosomal dominant. Intellectual disability with homocystinuria, normal intelligence or normal IQ with Marfan syndrome. The dislocated lens here in homocystinuria is low, similar to the IQ is low, and in cases of Marfan syndrome, the dislocated lens is upward or high, like the IQ is high. Limited joint mobility here, lax joint or hyper flexibility. Normal aorta, aortic dissection is a common association with Marfan syndrome. Thromboembolism commonly associated with homocystinuria. No thromboembolism associated with Marfan syndrome. Last section of protein disorders is urea cycle disorders. Very important to be familiar with these three names of urea cycle disorders. ornithine transcarbamylase deficiency is X-linked, and the rest is autosomal recessive: citrullinemia, argininosuccinic aciduria. These three names are very important to remember: ornithine transcarbamylase deficiency, or OTC, citrullinemia, argininosuccinic aciduria. If you have a neonate presents with lethargy, vomiting, coma, and death, hyperammonemia without acidosis, the most likely underlying cause is urea cycle disorders. It can be ornithine transcarbamylase deficiency, or OTC, citrullinemia, or argininosuccinic aciduria. The function of urea cycle is to dispose the ammonia, the toxic ammonia, to be non-toxic urea to be excreted in urine, and this process by deamination of the ammonia to non-toxic urea to be excreted in urine. If there is an enzyme deficiency in the urea cycle, this will be associated with a high ammonia level, and in cases of urea cycle disorders, the ammonia level usually very elevated, can be even in thousands. So this ammonia, when it reaches the brain, it will cause cerebral edema, altered mental status, lethargy, vomiting, herniation of the brain, coma, and death if it's not treated early. Newborn screen does not detect OTC. When you send urine organic acid, you need to specify that you desire to test for urine uric acid in order to detect this disorder, OTC, or ornithine transcarbamylase deficiency. Hyperammonemia is classic without acidosis. If there is an acidosis, will be because of shock or dehydration, but not directly like in cases of organic acidemia. So hyperammonemia without acidosis, very low blood urea nitrogen, which is unique, hyperammonemia level and low blood urea nitrogen. Then you test the plasma amino acids for a specific elevation of certain amino acids, and you test the urine uric acids. You will test the urine uric acid, and this need to be specified if you are thinking about urea cycle disorders. Important to remember again the common types of urea cycle disorders: OTC, citrullinemia, argininosuccinic aciduria. A specific lab for each disorder. For OTC, you will see elevation of ornithine, glutamine, alanine levels, and relatively low citrulline level, and increase urine uric acid, and this need to be specified when you order. Citrullinemia will be elevation of citrulline in the plasma amino acids. In cases of argininosuccinic aciduria, elevation of argininosuccinic acid in blood and urine. Initial management of urea cycle disorders, the acute management is dextrose. So again, dextrose is the best initial treatment for any metabolic disorders. Dextrose 10% with salt, so you will never go wrong starting dextrose. Early use of fluids, sodium benzoate, phenyl acetate, arginine dialysis. Chronic management to low protein diet, supplemental food, phenyl butyrate, arginine citrulline, liver transplantation in severe cases. We'll start a new section: fatty acid oxidation disorders. The key word for this disease: prolonged fasting, or a sick child and not eating or not drinking, like vomiting, diarrhea. When these children with fatty acid oxidation defect, they are sick, they cannot fully metabolize the fatty acids, so they will develop hypoglycemia, low blood sugar, without ketosis, without metabolic acidosis. So this is abnormal. Normal children, when they are deprived from glucose or a source of energy, they will consume the fatty acids, and they will develop metabolic acidosis. Children with fatty acid oxidation defect, they will develop hypoglycemia but without ketosis. The most common condition associated with fatty acid oxidation disorder is MCAD, and these children, they present with lethargy, vomiting, sudden infant death syndrome, Ray's syndrome. They present with coma, lethargy. Long chain fatty acids is different a little bit, and these children, they present with cardiomyopathy and rhabdomyolysis. Management of medium chain acyl-CoA dehydrogenase deficiency, MCAD. Avoidance of fasting, supplementation with carnitine, administration of dextrose during acute episodes. Prevention: avoid fasting more than 4 to 5 hours, so do not order fasting labs. Fasting is contraindicated in these conditions. Carbohydrate snacks at bedtime, carnitine may be helpful. Unfortunately, 25% of these babies they die before the result of the newborn screen. We'll start a new section, carbohydrate disorders. Common examples of carbohydrate disorders: galactosemia, galactokinase deficiency, Van Gerke disease, myocardial disease, deficiency of fructose 1,6 biphosphonate aldolase, fructokinase deficiency, mucopolysaccharidosis. A newborn presents with hypoglycemia, liver dysfunction, jaundice, coagulopathy, E. coli, sepsis, and cataracts. This is a classic presentation of galactosemia. E. coli, sepsis, and cataracts are keywords for this condition. Galactosemia is because of deficiency of GALT enzyme, and this will cause accumulation and elevation of galactose and galactose 1-phosphate, and this will cause toxic effect in the liver and will be associated with hypoglycemia and liver dysfunction, and will accumulate in the lens and will cause cataracts. The diagnosis: reducing substance in urine. However, absence of reducing substance in urine does not rule out galactosemia. Very important to keep in mind. Genetic testing and GALT enzyme activity and blood galactose 1-phosphate values is diagnostic. The treatment is simply elevation of galactose and lactose from diet for life. Very important to be familiar with the common complications of galactosemia. Even with early detection and appropriate treatment and excellent control, many still develop tremors, specific learning disabilities, speech language deficit. Many females develop ovarian failure. This is a high yield and often requiring estrogen replacement in adolescence. Remember, galactosemia is rare in real life but is common in the pediatric board examination. Galactokinase deficiency is another type similar to galactosemia but without systemic complication. These patients they present with cataract alone, only cataract, and the treatment is restriction of galactose. Newborn infant presents with hypoglycemia, lactic acidosis, hyperuricemia, hyperlipidemia, neutropenia, hepatomegaly without elevated liver enzymes, dull-like face, fatty cheeks, and thin extremities. This is a classic presentation of Van Gerke disease. Van Gerke disease is because of deficiency in glucose 6-phosphatase enzyme. So the liver will not be able to release glucose from the glycogen, and this large amount of glycogen will keep accumulating in the liver and will cause significant hepatomegaly and distension of the abdomen. And these patients, they can present initially with seizure because of hypoglycemia, and because of lack of gluconeogenesis this will be associated with lactic acidosis, and the lactic acidosis will cause metabolic acidosis, and this can present with hyperventilation or tachypnea. And the hyperuricemia, because of decreased excretion and increased degradation of tissue, will be associated with elevated level of uric acid. And the hyperlipidemia, because of low insulin level, because of low blood sugar, this will be associated with elevated triglyceride up to 800 milligram per deciliter. So hepatomegaly, hypoglycemia, seizures, lactic acidosis, hyperuricemia, high triglyceride level. This is Van Gerke disease because the liver cannot break down the glycogen to glucose. So if you give them glucagon, for sure this will not elevate the blood sugar, and with these patients they will continue having hypoglycemia even with glucagon, and this is diagnostic. The test will be confirmed with genetic testing. The treatment is to give them ready glucose to absorb without need to go through the liver for a breakdown. So uncooked cornstarch will sustain the blood glucose for 4 to 6 hours, and this will save their lives and will prevent the hypoglycemia. For young children, continuous nasogastric tube feeding, especially at night, of glucose is necessary to sustain normal blood glucose level, especially at night. This point is a high yield, and remember again, hypoglycemia, lactic acidosis, high uric acid, high triglyceride, and hepatomegaly, very large liver. This is Van Gerke disease. If you have a child that presents with muscle cramps after strenuous exercise, if you do laboratory testing and you find the CPK or creatinine phosphokinase is elevated and myoglobin in urine, this is a case of myocardial disease. Myocardial disease because of deficiency of myophosphorylase enzyme. Deficiency of myophosphorylase enzyme. The treatment: avoid strenuous exercise to prevent rhabdomyolysis, and oral fructose or glucose intake can improve the exercise tolerance. This is high yield. Deficiency of fructose 1,6 biphosphate aldolase enzyme or fructose intolerance. These infants are healthy until the mom starts introducing fructose or juices or sweetened cereals to the infant, and this will cause accumulation of the fructose in the body, in the blood, and by unknown mechanism will affect the liver and will present with jaundice, vomiting, lethargy, seizures, and irritability. If you do urine test, it will be positive for reducing substance, and the treatment is to avoid all sources of fructose, sucrose, and sorbitol. So the key word, healthy infant until the fructose is introduced to the infant. Then they will have symptoms, and the treatment is to avoid the fructose, sucrose, and sorbitol. This is autosomal recessive, present usually classically at 4 to 6 months of age, or earlier if the fructose introduced earlier, or later if it's introduced later. So depending on the introduction of the fructose or sucrose to the infant. Two easy and important conditions to discuss in this section is galactokinase deficiency and fructokinase deficiency. Galactokinase deficiency presents with cataract with no systemic symptoms, and the treatment is restriction of galactose. Fructokinase deficiency is asymptomatic. They present only with fructosuria and no treatment is necessary. Lysosomal storage disorders. These conditions are progressive. So the infants are born normal, then they will start to have progressive symptoms because of accumulation of large molecules in different tissues. For example, mucopolysaccharides, sphingolipids, and oligosaccharides within vulnerable tissues. This will cause large liver and spleen, bony deformities, developmental regression like loss of milestones. So the child was sitting but not able to sit, the child was walking but cannot walk anymore, sensory loss, hearing or vision, coarsening of facial features, and compared to the family members, you will see the infant or the child is different. The common conditions associated with lysosomal storage disorders, Hurler syndrome is autosomal recessive associated with corneal clouding, is a key word for Hurler, and Hunter syndrome is X-linked and without corneal clouding. Sanfilippo's syndrome, autosomal recessive, they do not have visceral and bony manifestations similar to Hunter and Hurler, is less visceral and bony manifestations in case of Sanfilippo's syndrome, but they have large organs and developmental regression, coarsening of facial features. Another common lysosomal storage disorder is Tay-Sachs disease. It's common in Ashkenazi Jewish but can occur in any other ethnic group. Associated with beta-hexosaminidase deficiency, presents with weakness and exaggerated startle reflex or myoclonic seizure triggered by voice or loud noise. They have cherry red spots in the retina and no visceromegaly. Fabry's disease is X-linked, associated with alpha galactosidase deficiency. The common presentation is painful hands and feet and recurrent abdominal pain. So Fabry's, they present with fabulous pain, proteinuria, and renal insufficiency. Gaucher's disease associated with beta-glucocerebrosidase deficiency. The common or the most important point or the key point in this disease to remember is splenomegaly. They present with very large spleen, anemia, and thrombocytopenia because this disease affects the bone marrow as well. Krabbe's disease is galactosylceramidase deficiency associated with increasing in muscle tone, profound irritability, seizures, vision loss. Vision loss is a very important presentation of Krabbe's disease and developmental regression. Pompe's disease is acid alpha glucosidase deficiency, presents with hypertrophic cardiomyopathy in infants, skeletal and respiratory muscle weakness. Its elevation of CK is a key word for Pompe's disease and cardiomyopathy. So these two words very important to remember about Pompe's disease: cardiomyopathy, elevated CK. Wolman syndrome presents with poor feeding, failure to thrive, high triglyceride level, hypercholesterolemia, bilateral adrenal calcifications on CT scan. This is a key word for this disease to remember. Zellweger syndrome is a peroxisomal disorder because of very long chain fatty acids oxidation defect. This involves all the body organ, including brain, liver, kidney, muscle. So you will see the effect of this disease in all the body tissues. So these patients, they will present with dysmorphic facial features, a prominent forehead, seizures because it affects the brain, liver diseases like jaundice, characteristics bone involvement, profound hypotonia, developmental delay, hearing and vision deficit. The initial screening is plasma, very long chain fatty acid analysis. Magnetic resonance imaging or MRI will show abnormal myelination. This condition is usually fatal in infancy. Adrenoleukodystrophy is another peroxisomal disorder. Is X-linked, affected the boys because of deficiency in peroxisomal oxidation of very long chain fatty acids. They present with developmental regression, spasticity. The key word for this disease, adrenal failure. Adrenal failure, typically in school age boys because it's X-linked. Initial screening is very long chain fatty acid analysis. Stem cell transplant may halt the progression in some patients. Mitochondrial disorders, MELAS. MELAS is a high yield. The MELAS stands for mitochondrial encephalopathy, lactic acidosis or elevated lactic acid, stroke-like episodes. Other features of this disease is short stature, cardiac disease, hearing loss, endocrinopathy, exercise intolerance, neurodegenerative disease. But remember about MELAS, mitochondrial encephalopathy, lactic acidosis, stroke-like episodes. Another important mitochondrial disorder because of defective phosphorylation in the mitochondria is Kearney-Sayre syndrome. Kearney-Sayre syndrome presents with cardiac conduction abnormalities, cardiomyopathy, lactic acidosis, and the progressive external ophthalmoplegia. So this patient, they will have problem with the eye movement and the drooping of the eyelids. So this patient, they may need pacemakers, they need vitamins, but there is no cure for this disease. The summary of this presentation, when you have a patient to present with suspected metabolic disorder, you need to order basic metabolic panel. Basic metabolic panel will give you a lot of information. Basic metabolic panel includes sodium, potassium, CO2, which a reflection to the bicarb, chloride, BUN, creatinine, glucose, and calcium. If you see metabolic acidosis, which will be low CO2 and elevation of anion gap, this will be a key for organic acidemia. The ammonia level can be mildly elevated or severely elevated or even normal. So organic acidemia can be associated with normal, mild elevation or severe elevation of ammonia level. But the key for organic acidemia is metabolic acidosis, and this what will make the difference between organic acidemia and urea cycle disorders. If you have an infant or a child present with hypoglycemia without metabolic acidosis, without ketones, this is a possibility of hypoketotic hypoglycemia. Hypoketotic hypoglycemia can be caused by disorders of fatty acid oxidation, meaning that the infant is not able to use the fatty acid as a source of energy. Also, another condition can cause that, hyperinsulinemia. Let's learn more about ammonia before we order it. Ammonia level more than 100 is dangerous, is a high risk of cerebral edema, encephalopathy, herniation of the brain, and death. So has to be taken seriously. Conditions are associated with high ammonia level more than 100. Urea cycle disorders, organic acidemia. Urea cycle disorder can be associated with extremely high level of ammonia. Very important to know the false elevation, causes of false elevation of ammonia level, so you will be able to understand the lab better and take a better action. So venous compression from tourniquet. So tourniquet use can cause false elevation of ammonia level. Proper handling of a specimen, if it's left at the bedside or left in the lab before testing for a long time, this can cause false elevation. So when you have an ammonia level like, say for example 90 or 80, you need to follow it closely, but with proper handling of the sample, like for example the sample to be obtained without tourniquet and to be placed on ice and immediately sent to the lab. So a slight elevation of ammonia level, it can be simply repeated, especially if the patient is asymptomatic. Elevation more than 100 has to be taken seriously. The patient has to be retested immediately. If the patient is symptomatic, has to be sent to the ICU for further action. How to understand urine ketones in the cases of metabolic disorders. For example, cases of organic acidemia associated with ketonuria, cases of fatty acid oxidation disorders or hyperinsulinism associated with hypoketotic, low ketone, and hypoglycemia. So hypoglycemia with no ketone in urine, so no ketonuria. This is a key for fatty acid oxidation disorders and hyperinsulinism. So very important. This is high yield. This is how to differentiate these conditions in the pediatric board examination and in real life. Lactic acid. When the lactic acid is elevated, this is commonly associated with shock, hypoxia, poor tissue perfusion, but can be associated with rare metabolic disorders, for example, Van Gerke disease, MELAS, or Kerniser syndrome. Plasma amino acids, very helpful test for diagnosing of many metabolic disorders. For example, phenylketonuria, you will see the phenylalanine is elevated, tyrosinemia, elevated tyrosine level, maple syrup urine disease, elevated leucine, for example, urea cycle disorder, citrullinemia, elevated citrulline, organic acidemia is associated with elevated glycine. So when you send plasma amino acids, you need to know what to expect. Urine organic acids is very helpful in the diagnosis of multiple metabolic disorders, for example, organic acidemias, fatty acid oxidation disorders, amino acidopathies. The best if it's done during illness or fasting. Plasma acylcarnitine profile. Very important to be familiar with acylcarnitine profile, and the elevation of acylcarnitine profile can be associated with fatty acid oxidation disorders and organic acidemias. The carbon chains connected to or linked to the carnitine is from C2 to C18, and in the newborn screen you will see these numbers. So if you see elevation of C3 and C5, this is suggestive of organic acidemia. If you see elevation between C6 to C10, this can be associated with fatty acid oxidation disorders, and the most common is MCAD. So this is important when you have a newborn screen to be able to understand where is these C's or these carbon chains came from. So the carbon chains linked to the carnitine is from C2 to C18. C3 and C5 elevation is associated with organic acidemia. Elevation between C6 to C10 associated with fatty acid oxidation disorder, most commonly MCAD. Newborn screening. Tandem mass spectrometry, acylcarnitine profile, amino acid analysis detects many disorders, but very important to know false negative results can occur, and you should have a high index of suspicion even if the newborn screen is negative. Some disorders are not currently part of the screen. Very important to know that. If you have a positive newborn screen, you have to take an action and take it seriously depending on the underlying condition. Finally, if you do not remember anything in this presentation, at least remember metabolic acidosis plus normal or high ammonia level is suggestive of organic acidemia. Respiratory alkalosis plus very high ammonia level and low BUN is urea cycle defect. Hypoglycemia with no ketones, with no ketosis, with no ketone in urine is suggestive of fatty acid oxidation defect or hyperinsulinemia. This is the end of this presentation. Thank you.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, By studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This lecture is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician and the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.